Okay, so this one's over hemolytic disease of the fetus and newborn, which is called Hdfn. And then it's also called erythroblastosis. Erythroblastosis fetalis. And so what happens is fetal red blood cells are destroyed by maternal IgG. If they ask you which immunoglobulin that that it's referring to, how do you know which one?
IgG crosses the placenta?
Yes, IgG crosses the placenta. So mother is sensitized to fetal antigens present or not present on the mom cells.
Present.
Nope, not present.
Not present. I always get those backwards. I know it. I just get them backwards.
Yeah, so whatever mom doesn't have, she can make antibodies to and attack the baby cells. And then her antibodies bind to the fetal antigens. And that leads to red blood cell destruction in the baby. And so what happens is the baby RBCs coated with maternal antibody are sequestered or destroyed once they reach the baby's liver and spleen. So the antibodies go and coat the red cells, and then the red cells are traveling, the coated red cells are traveling through the baby, and once they get to the liver, the spleen, they are cleared out, and that leads to an increased bilirubin and hemolysis in the baby. And another requirement is that the antigen must be, first it has to be IgG, and the antigen must be well developed at birth. So this is all about fetomaternal hemorrhaging. And they call that FMH sometimes. And when can this happen? Y'all know some cases where this can happen? It can happen in delivery. It can happen when you do any kind of procedure like an amniocentesis or a cordocentesis. What's some other things that can happen?
Is that one that can happen in like with a crushing injury?
Yes, so that's one. Any kind of abdominal trauma. So any kind of wreck or accident or fall or anything like that that can cause bleeding. Mine, they were trying to decide early in my first pregnancy to give me rhogam or not. I was on birth control, so I was completely unaware of being pregnant, and I ended up moving like shortly before that, or shortly after getting pregnant. And so I had a small tear from bleeding from moving, so they gave me extra rhogam then. And then another one's abortion, which is probably the most common. So a lot of times there's either or miscarriages. There's that risk of the blood interacting at that point as well. Do y'all remember how many mils of blood are required to trigger antibody production, specifically for the Rh group?
I just went over that. Could have sworn it was like, wasn't it 0.
Yep, it's a good start.
0.1
mil. What?
One. I went too high. I said 0.05 at 0.01, isn't it?
Yeah, 0.1. 0.1 mils of blood with a positive Rh is all it takes to sensitize the mother. So that's Rh specific. But if you think about it, 1 tube of blood is approximately 3 to 5 mils. And so that's a really, really small amount. Okay, so bilirubin. What's bilirubin? Well, don't everyone shout at once.
It's the stuff that makes the baby turn yellow.
Yes, that stuff. From red blood cell breakdown, right?
Yeah.
So product of RBC breakdown. And now this prenatally, the mom filters the blood through her liver and then returns it back to the baby. So mom filters.
When you get through it, I got a question.
What?
When you get through with this right here, I got a question.
Okay. So the mom filters the blood, and she will take the indirect bilirubin and then conjugate it by her own liver. Mom filters Billy from indirect to by the maternal liver. And then releases the baby. Sorry, go ahead.
So, I don't know. This is what confuses me. You have prenatal and you have perinatal.
Uh-huh. So prenatal.
Before? I mean.
Before birth. And then your postnatal is after birth. So this is what prenatal is when she's pregnant, and then postnatal is after the baby has been born.
Right, but in the book it has prenatal and pernatal.
Oh, I think that means the same.
So it's this exact same thing. They're just kind of throwing you off.
Yes.
Okay,
Let's
that's what I thought. But
and you said it was pronatal?
PER natal instead of pre, it's PER natal. And I was just like, if it's the same thing, why use two different terms for it? Just use the same term.
I don't see it. It could have been a like a accident too.
Here, look, I got my
Okay.
BO book. BB book.
And postnatal, as far as bilirubin goes, can babies process bilirubin?
What now?
Can their livers process bilirubin?
No.
No. So babies are unable to process bilirubin. That's why they get jaundice, is because their mom was the one that was processing their bilirubin, but after they're born, their livers don't work for a while. So they cannot conjugate the bilirubin. And what happens is that bilirubin binds to albumin and to tissues, causing jaundice. And so bilirubin has an affinity for lipid-rich layers of skin and brain, and is a potent neurotoxin that can cause brain damage. So it has a high affinity for lipid-rich layers of skin, which would be, your tissues and including your brain. And so what happens if it gets into the brain, it can cause kernicterus, which leads to brain damage or death. And so that is the whole thing that they're trying to avoid when keeping babies' bilirubins down. The whole point of keeping their bilirubin down is to prevent this brain damage. So jaundice. Yellowing of skin and surfaces. And actually, I'll go ahead and put kernicterus down here. I think that fits a little better. Well, it is just trying to make me retype. There we go. So kernicterus causes brain damage. And the treatment of choice is going to be phototherapy. Because what does light do to bilirubin?
It helps get rid of it.
Yep, light breaks down bilirubin. And that's why you have to have it protected from light too in the lab. Now there's different types of Hdfn. What's the most severe?
What now?
The most severe cause of hemolytic disease of the fetus and newborn?
Is it anemia?
Nope. What antibody?
Is it the ABO?
Nope.
Whoa.
RH?
RH.
We'll guess it here.
So
You made it eventually.
that's always the goal, right? Is the most severe. So RH and RH incompatibility is actually a lot worse than an ABO incompatibility. So RH is the most severe, even more than ABO. And what is your most immunogenic blood group antigen? The most immunogenic blood group antigen. I'll give you a hint. It's part of the Rh system.
D.
D. So the D antigen is the most immunogenic. Do y'all know the second most immunogenic?
So what was that before that? The
The
D is the most.
Most immunogenic, D antigen. And then this is not part of the Rh system, but the second most immunogenic, it's a good thing to keep in mind, is what? It's going to be
ABO.
Kel.
Kel.
So Kel is the second most immunogenic. And if you notice, both of these, D and Kel, are both well developed at birth.
Are both what?
Well developed at birth.
Okay.
And then remember, so less than 0.1 mils of Rh positive blood can trigger antibody production. And so it's good to keep in mind that the average yeah, I'll just put 2. The average blood tube is about 3 to 5 mils. Now, who is at risk for hemolytic disease of the fetus and newborn? Hdfn, in reference to Rh, what does the mother have to be?
Negative.
Yep, so D negative mothers and D what baby?
D positive.
And a D positive baby are at risk for Hdfn. So generally, the mother will be sensitized from the first pregnancy, and then impact subsequent pregnancies. And subsequent just means future pregnancies. So this time she'll come into contact with the blood, make the antibody, and then in the any future positive babies. So that's the big difference. People, I think, confuse that sometimes. Any future D negative babies are fine, but any future D positive babies will be seen like, you know, like that foreign invader, and they're like, "Ooh, I got this. I know what it is. I'm getting rid of it."
So it doesn't affect. That's why it doesn't affect the first baby.
It doesn't. The first baby isn't affected because she has to have time to make the antibodies.
So there's no way to determine that beforehand. Like if you were knowing you were going to have kids and you're an O group mother and you're D negative, there's no way to determine that.
No, but now, and it used to, you know, prevent a lot of babies from coming in this world, but now they have the rhogam.
Right.
Even if they think it might be a thing, like they're going to go ahead and give it.
So when they give them the rhogam for the second pregnancy, then they don't have to give it again for the other pregnancies.
Well, they give it the first pregnancy, and then that way they don't have to give it. Well, then they'll give it every single pregnancy to a D negative mother.
Okay, okay. So they have to go through that process, not only on the first baby, but all the way
Every single
through.
time. Yes, because what happens if they don't do it every single time, then they run the risk of being sensitized, and after that, there's not much you can do. It often yields a positive DAT. And now these are, let's see, maybe result. Where is it? Oh, let's see. So jaundice and anemia in the baby. And might require possible exchange transfusion, which is where they go in and remove the, they will remove the coated cells, the antibody coated cells of the baby with cells that are not going to go and be sequestered later. Now prevention. Luckily, we have an amazing thing that helps prevent it now, and it is your rhogam. So it can be called rhogam. It can be called your RhIG. And what the RhIG stands for is your Rh, immune globulin. Because it's IgG, so that's shortening. Instead of having like IgG, it's immunoglobulin G.
Imagine walking into a train and witnessing something as exquisite as this, a small on a train.
Whose TV is that?
And then the only thing about rhogam though, it only protects from Hdfn caused by anti-D. And you can, any kind of IgG, any kind of IgG can cause hemolytic disease of fetus and newborn.
Well, that's super annoying.
So is there anything that can be done for, like, say, like with a KEL?
Nope. Or at least not that I know of anyway. I'm sure doctors have ways to do better, but and also those are less severe forms, so it does prevent against the most severe kind of Hdfn, which is your Rh. Okay, and I'm going to do the rhogam on its own page. So it's recommended for who? Any
D-negative mom.
D-negative mother. Yep, so any D-negative mother. And then specifically any D-negative mother who has abdominal trauma, abortion, invasive testing, miscarriage, anything like that to where the blood could mix. And they actually give it to any D negative mother at 28 weeks, period, without any of these. So, and then, any D negative mother at 28 weeks gestation. Now, antepartum is going to be like when you're still pregnant, and that's at 28 weeks. They give a 300, or one vial is this 300 UG initial dose.
And what
And
did you said antepartum was during birth?
no, before. So before birth. So their initial dose is at 28 weeks gestation, and this is also the equivalent of one vial or one dose. And then postpartum. Do they know antepartum if the baby's positive or negative?
Can they know?
Do they?
Oh, do they? Yeah. Yes.
Yeah, no, not antepartum. Unless they could possibly, but they're not going to go in and do invasive procedures that could kill the baby when it doesn't harm them to get the rhogam anyway. So they don't know. That's why they give it to every mother. And then postpartum, as soon as the baby's born, they will type the baby's blood, and then they'll get one vial within. Do y'all know the time frame you have to have it within?
Oh, 72 hours.
Yep, within 72 hours. If they have a D positive baby. And then your one dose or vial, which is that 300 UG, will pretty much cover up, or is effective against and let's see, neutralizes 30 mils of whole blood. Now, do y'all know what the screening test is? To know how much, or if you need rhogam? So your screening test is going to be the Rosette test. And you use a postpartum maternal specimen. And then the maternal RBCs are incubated with anti-D. And then you add D positive indicator cells and then you do a microscopic analysis. And now this microscopic analysis is considered negative if you have less than 1 rosette per 3 low power fields. So LPF is low power field. And in that case, you would get 1 dose or 1 vial. Just know that it means 1 dose too. I prefer saying 1 vial. I think it's more specific, but it doesn't matter which one you use. And then positive is anything greater than 1 rosette per 3 low power fields. And if you have more than 1, then you have to do a quantitation testing. So requires and I got a picture of a rosette. Kind of hard to see that one. Let me show you all.
So if they have more than 3 of those dark,
Nope, more than 1.
more than 1?
1. Yep, in 3 low power fields. So if you're on low power, you look at it and then move to another field, and then look at it and then move to another field. And if there's more than 1 out of those 3 fields, then it's positive.
Okay.
It's kind of hard to see this one too, but if you just Google like the rosette, it kind of looks like a bunch of them together. Sorry, I just saw the chat. Yeah, we're going over chapter 12, the hemolytic disease of the fetus and newborn. Okay. Okay, so then your next thing is going to be, so if you have a positive screening test, and then you need to do some sort of quantitation testing. So let me put in here that quantitation testing is either a KB test or flow cytometry. So the main one's going to be your KB test, which is that Klauer-Betke. I don't know, I've heard it said a few different ways. LEI. Oh, yeah. There we go. So your KB test determines how many additional doses are required. And it runs on the basis that fetal hemoglobin resists the acid, and it ends up retaining dye, which turns it like a pinkish color. And then on the same basis that adult hemoglobin resists acid. And I think y'all generally just use HB and not HB for hemoglobin, right?
Yeah, that's fine.
Usually, or I think that y'all's hematology book did it a little different than mine, but however you put it. Adult hemoglobin resists acid, and it makes them ghost cells. Please. Now the calculation. I know y'all are so excited. Calculation. Made it all week without like using math, and now here we go messing that up again. So first note, always add what's called a safety vial, which is simply an extra vial. Then what you do is you count 2,000 cells. Yes, you count all 2,000. So 2,000 cells. And then you note the number of fetal cells and note the number of maternal cells. And then you divide the number of fetal cells by 2,000. And then you multiply the result of that, dividing the fetal cells by 2,000 times 5,000. And that gets you the volume of fetal whole bleed, or the fetal hemorrhaging. Then once you have that number, you take that and divide it by 30. Why do you divide it by 30?
It's 1 vial for every 30 milliliters.
So each vial neutralizes 30 mils. So you divide it by 30 to see how many actual vials you need. And now some rules to go by, and we'll do an example here in just a minute. But the rule is if it's greater than anything 0.5, so I'm going to put x 0.5, but just know that can be 1.5, 7.5, 6.5, any kind of number with a decimal place. Greater than 0.5, you round up. And then anything less than, you know, the equivalent of whatever the number is, 0.5, you round down. And then again, it's really important, you always add 1. So do you want to use an example from the homework, or do you want to use the one from the purple and yellow book, or?
Yeah, I've got a couple in here as well.
Okay.
Like this one says, how many milliliters of whole blood from a FMH is covered with a 300 dosage of RhIG?
Can we do that one afterward, and just for this one do like the cells? Do you have one with the number of that gives you the number of fetal cells and the number of maternal cells?
I have one that goes over fetal hemorrhaging, how you add that up.
Okay, let me do this one, and then we can go over the homework questions afterward.
All right.
So this one gives 8. So the number of fetal cells was 8, which means how many maternal cells were there?
$1,992.
Yep. Because it's whatever left is out of 2,000, right? So first what we do is we take our...
So you subtract whatever fetal cells they have from 2,000?
Yes, to get how many maternal cells there are. But just remember, when you're counting them, you'd be counting them all. And so what I would do is just take two counters and sit there and count all the maternal. And then when I come across the fetal cell, count that one on the other counter. And then just keep in mind that you're adding them together. But it makes a little more sense if you're like looking at it and doing it in the lab. So you divide your number of fetal cells by 2,000. So if it's saying we have 8 fetal cells, you take 8, divide that by 2,000. Which is 8 and 20. Is 0.004. And then what do we do next?
Multiply that by 5,000?
Yep, so you multiply that times 5,000, which is 20. So we multiply that times 5,000. That's 20 is our volume of the fetal whole bleed. Now we divide the fetal whole bleed by 30 mils. So you take 20, you divide that, so you put 20 mils over here, divided by 30. is 0.666. 0. So if it's 0.666, we can round it up to what, 0.67. And now what? What do I do with that number?
So is that
Round up to 1 vial.
Yep. So if it was below 0.5, you would round down, which would be 0, and then add your extra, which would make that 1. So for this one, you round up, so you get 0.67 is equivalent to, you round up to 1 vial, and then you've got your 1 vial, and you add your safety vial, which means you will need 2 vials or 2 doses of your rhogam.
okay? I get everything up until where you round up and down.
Okay, so you've got 0.67.
Well, I thought it was 1 vial for every 30 mils, so that would be
So we
Good.
had 20 mils
okay.
was our like hemorrhaging number, our bleeding.
Right.
And so that divided by 30, because 30 is every vial. This is the actual quantification of it. You could look at that and say, okay, 20 mils needs 1 vial, and then you add your safety vial because it's, you know, close to 30. But the actual math for it would be to divide that number by 30, which gives us 0.67, which is you round up. If it's over 0.5, you round up, and if it's below 0.5, you round down.
Mhm.
And so it rounds up to 1.
So let's say that was 0.47. Then that would be equal 0 vials, and then you add your safety, which would be 1, right?
Correct.
Okay.
Yes, you just get 1.
Alright.
And I think I got a picture of this one too. So see these darker ones are all fetal cells, and then these light pink ones are the ghost cells. So they still have like a pinkish tint to them, but they're not as dark as the fetal cells are.
Okay.
And then I wanted to show y'all one that kind of has some discrepancies in it. Maybe not necessarily discrepancies, but different options of what you could be looking at.
Oh,
Okay, so here's the normal ones. Here's your maternal red blood cell, and then your fetal red blood cells. And then here's one that shows a weak positive. So that could be easy to confuse with the maternal. And then a neutrophil. So don't get the neutrophils confused with the red blood cells. You know, they're obviously larger. They have the chromatin. Overlapping cells can make it look positive. See how the more they overlap, the pinker it looks? So watch out for overlapping cells, contaminants of any kind. And then here's a broken red blood cell just from probably the slide making process. And now note that it is not just your rhogam, can be used for transfusions as well. So if they only have D positive blood and they need it, then they can go ahead and transfuse the D positive blood and give rhogam as well. Okay, now that's ours on rhogam, and keep in mind that your rhogam only protects against your Hdfn, specifically your anti-D. So do y'all know the other Rh blood group, or that one's a blood group? Which antigen causes Hdfn? Not as much as ABO and Rh, or ABO and D. There's another one from the Rh group that can cause Hdfn as well.
Is it that C H A?
Little c causes Hdfn sometimes too.
Okay.
So another type is ABO. It's going to be less severe, but it is the most common. And you will have a group O mom, a group A or B baby. Why not a group O mom with a group AB baby? Why not a group O mom with a group AB baby?
I don't know.
Think about it. What genetics do you have to get to be AB?
What now?
What genetics do you have to get to be AB? To be type AB? So it can't be AB. It can't be a group O mom with an AB baby, because mom has to give mom's O, which is recessive. So she is type OO, and so she has to give an O to the child. So the child can get an A or a B or an O from dad, but they have to get an O from her. So they can't be AB because she has to have at least one O in there.
Okay.
Make sense?
Yeah.
So it's either going to be a group A or group B baby with a group O mom. And these antigens are often poorly developed at birth. And that is partly why they are less severe. Not all of it, but a big part of why it's less severe. So the antigens are poorly developed at birth. And then there's other types. Remember, any IgG can cause Hdfn. So any Ig. And what did I say earlier is the second most immunogenic blood group antigen?
Oh,
Kel. Yep. So Kel is your second most immunogenic blood group antigen, and it is well developed at birth. And so another common Hdfn, not as common as ABO and Rh, but more common than other ones, is anti-Kel. And then the other one from the Rh is going to be your anti-little c. So these are just slightly more common than the low frequency antigens. So first you have Rh and ABO. ABO is the most common, and then Rh, and then your anti-Kel and anti-little c. And then after that comes low frequency antigens. And then the best way to find out if it's a low frequency antigen is to check for agglutination between paternal RBCs and maternal serum. And y'all are all aware that the babies get these antigens that the mom doesn't have from dad, correct? Everyone's on the same page there. So prenatal testing, when's prenatal?
Before.
Before birth. So while she's pregnant, and what they do is they will test mom's ABO and Rh, and then they will test for mom's antibody screen. So this covers all your types of ABO, or all your types of Hdfn, because you got ABO, you got Rh, and then any of your antibodies like Kel, little c, and low frequency antibody will be caught on the screen. Then they've got antibody titration, or an antibody titer. It determines if certain procedures should be performed. Give me just a second, guys. My son's dad's called a couple times, and so is my friend. So I want to make sure it's not an emergency.
Can we take like a 5-minute break?
Okay, so antibody titration or titers determines if a certain procedure is required. or should be performed. What's an example of a procedure that might be required or performed? So it could be either doing like an intrauterine transfusion, or if the baby needs to be induced early, or if they can carry to term. That just kind of helps decide, okay, this is where we're at, this is where we can get to before taking other measures. Because it's not always good to induce someone early, and it's definitely not always, you know, the safest thing to do an intrauterine transfusion. And so these need to be, they need to be sure that these are necessary procedures. So what they do a baseline in the first trimester. And then they do testing every 4 to 6 weeks. Four to 6 week intervals, meaning every 4 to 6 weeks. And then just note that they freeze all samples in case they're needed for future testing. Do y'all remember what the significant dilution rise is?
The significant what?
Dilution rise. So how much a dilution has to change to be considered significant?
Is if it changes more than, like if it goes up like more than 1?
More than 2, actually. So a 2 dilution rise is going to be clinically significant. And that is because it's one of those things where there's going to be like a tech variance. So like if you look at a urine dipstick and I look at a urine dipstick, we can, you know, be about one color code off. And so if I did it and then someone else went and did the same test, they can be off 1 dilution. But once you're getting off, you know, 2 or more dilutions, then that's not a tech variance. That's an actual rise in the titer. So 2 dilution rise is considered significant. And then an RH critical is going to be 16 or 32. And I'll tell you, remind you what that means here in just a minute. So 16 or 32. And that's approximately tube 5 or 6. And then your Kell critical is going to be 8. And what do I mean by that? Let me show y'all. I think I saved the picture too. If not, I have it on the internet. Okay, so you remember these? So this is tube 1, tube 2, tube 3, 4, 5. I know it was so much fun. So I'll never forget it. So 20, 40, 80. Then you got your 16, 32. So at tube 5 and 6 here would be a critical for RH. And then here's your 8 is tube 4 would be your critical for Kell. So that's what that's referring to with the titration. And if it's saying the critical is 16 or 32 or critical is 8 or the titration is 4, then you would get, it would stop here at 3, tube 3. And then it also talks about It also talks about ultrasound, and I'm going to touch on that a little bit later, though. So amniocentesis is next. So they take the sample of amniotic fluid. So you take a sample of amniotic fluid, and then you scan it spectrophotometrically. And they happen to do it, I don't think you'll get tested on it, but they happen to do it at 350 to 700 nanometers. And then a change in the optical density. So a change in optical density is equivalent to a change in bilirubin. So bilirubin increase. And then they take this and plot it on a lilograph. Have y'all learned about lilographs or lilograph? I think it's actually a lilograph. Let me double check. It's actually L-I-L-E-Y. I wonder if I've been saying that wrong for a long time. Okay, can y'all see the page still? Lilograph?
Yeah.
Okay, and you'll learn about it in your analysis once you get to other body fluids. And so that tells you, based on that graph, you can tell whether the jaundice or the Hdfn, specifically the Hdfn, is severe, moderate, or mild. And so from that chart or that model, you can say, okay, well, they can either have a term birth, or we can induce them early. But to induce them early, they have to have a certain that sphingomyelin ratio for their lung development. So it requires lung maturity. To be able to induce them early. So the other choice is, if they're not ready to be born, but they're having too much hemolysis, then you can do an intrauterine transfusion. Next one is chordocentesis. And a chordocentesis is just taking a fetal blood sample. So if they can take a fetal blood sample and blood type the baby, why don't they do that before giving rhogam? To decide whether the baby's positive or negative at the beginning.
I don't know.
They don't want to cause accidental damage from an unnecessary procedure.
Yeah, so it's not the safest procedure. I mean, they do pretty good at it, and I think it's like, relatively I don't want to say low risk, but it can harm the baby. It could kill the baby. And so they don't want to take that risk at all if they don't have to. So if you can give someone rhogam and have zero side effects from that, they would rather do that than have the potential side effects of a chordocentesis or an amniocentesis going wrong. So the fetal blood sample can be used for hemoglobin and hematocrit counts. And then they'll also check for bilirubin. And they can also do the RBC genotyping, which is just, you know, seeing what their typing is, like their ABO, RH, all that fun stuff. And then it can also be used for the chordocentesis for intravascular transfusions. But that's only done in the cases of severe Hdfn.
So up there where you did those little valves and everything, when they run that test, if it gets to a certain severe point, does that tell them that they need to induce labor or get the baby out, or?
They got to do something because that baby's going to die. The baby's losing blood, and you know, whether the hemolysis is going on, like, you know, inside the stomach or outside of it, prenatally or postnatally, like it has the same effect. It's going to stop the heart. And so that's what they're trying to avoid. But, you know, they can't just say, okay, well, the baby's not doing good in the belly, so we'll just take it out of the belly. Because you have to have the fetal lung maturity before they can come out, or they might not breathe. So, you know, what's worse, them not being able to breathe or their heart not being able to work? You gotta, you're in the same boat if you take them out and they are not ready to be out yet. And so sometimes they can do that intrauterine transfusion instead if they're not ready to be born, but they need new blood.
So that's why if it's severe, then maybe they should run an ultrasound first before thinking about bringing the baby out.
Yes, and so that ultrasound can tell better too where the baby's at. So between that lilograph and your ultrasound or the color Doppler, then they can get a better picture of the baby as a whole, where they're at, when they need to take, you know, when the measures are the benefits are gonna outweigh the consequences.
Okay.
Okay, so now postpartum testing. Just note that this is the safest for baby. Testing. Who gets tested? All infants of
D-negative mothers.
D-negative mothers. So and I'm pretty sure they actually test all infants, period, to blood type them, but most certainly the ones of importance are all infants of D-negative mothers. Then you run the risk of a false negative, and to fix that, you can do an elution. And what happens with the false negative is that the D antigen sites are blocked by the antibodies. So they could really be B positive, but the antigen sites are blocked by the mother's antibodies. And then an elution will fix that. And then false positive. You can do weak D testing. and then you use a positive AHT control to double check. And then you've got ABO testing. What's special about ABO testing in newborns?
So for the D testing, like the false negative and false positive, so like anytime you get a negative, do you do the elution, and like anytime you get a positive, do the weak D testing?
I don't
Like,
know. I think
do
different
you do like
hospitals
a
will run different,
confirm?
like requirements as far as those go. Because I think there are times, and I could be wrong, where they just accept the result as a result. It might be some kind of thing that triggers like, hey, this doesn't look right, or it could be policy to do it on all of them. I never worked in blood bank, so I'm not quite sure of like everywhere's policy on it. But I think anytime you have like some sort of discrepancy, it's good to know what you can do to fix it or to double check it. I'll have to ask. I'm gonna ask someone sometime and see.
Because I
See if
didn't know if that was something
that's
like that's always done as a confirmation, or something like
Yep.
we would need to be looking for like a red flag.
Yeah. No, that's a good question. I'm gonna ask someone. All right. And then your ABO. What's special about ABO testing in newborns? Do you run forward and reverse?
Just forward.
Just forward. Only forward grouping. And that is because they don't have antibodies yet. And what's special about cord blood? What does it have that you might need to wash off? It starts with a W. Anyone know? This one will probably end up on some kind of question. So Wharton's jelly is often on the cord blood, and so sometimes you have to wash the cord blood cells to remove any of that Wharton's jelly.
What is Wharton's jelly?
It's kind of like a little goo that is over the baby and the cord.
Oh, okay.
I mean, it's pretty much goo that comes out with birth. Birth is gross. I don't know who was like, oh, this is a beautiful experience. Like, no, it's pretty nasty. They're all covered in blood and Wharton's jelly and gooey and vernix and all that fun stuff. Okay, so then a lot of times you get a positive DAT, but your DAT testing, you can do an elution, and if it's negative, then it's probably a low frequency antigen. And then if it's positive for A and B cells, and negative for screening cells, then it's probably ABO Hdfn. Then intrauterine transfusions. What does that mean? An intrauterine transfusion.
A transfusion like before delivery.
Yes. So while the mother's pregnant, the baby gets a transfusion. So this corrects anemia and prevents heart failure. It can affect your ABO and RH interpretations. Why is that? Because no matter what the baby is, they're gonna transfuse O negative, you know, CMV negative, hemoglobin S negative blood, and so whatever their blood type is gonna mix with that O negative. So it can affect those interpretations once they're born and you test them, and then your critical to kind of get this kick started for RH is going to be 16 or 32 at AHG phase. Kel will be 8 at AHG phase. An ultrasound establishes the severity. And what an ultrasound does is it can detect fetal anemia. And it does that by, it'll check the cardiac output and then the blood viscosity. So an increased cardiac output with a decreased blood viscosity can kind of signify that the baby has anemia. And they will transfuse group O, D negative, CMV negative, blood, and then there's a few more requirements that kind of go along with it. So the big ones are group O, D negative, CMV negative, and then a lot of times they'll do irradiated. I think it's every time, not just some of the times. So irradiated, and that prevents graft versus host disease. And then it needs to be hemoglobin S negative. And then it also has to be less than 7 days old. So your blood is not expired after 7 days, but to transfuse it in an intrauterine transfusion or into a new baby, it has to be less than 7 days old. And then I think if it's not CMV negative, I think it can be CMV negative and or leukocyte reduced.
So, going back up to that ABO, wouldn't ABO testing, wouldn't spirocytes be important?
So the spirocytes are important due to, let me grab my email real quick. Let me finish this one and I will show you the picture of them in between. Or no, I'll look at it real quick. Give me just a second. Okay, so here's the comparison of ABO and RH. Let me put it up where it actually belongs. Okay, so we've got our ABO versus RH. So your ABO Hdfn is generally going to have spirocytes. The DAT will be weak or negative. You'll have delayed jaundice. Bilirubin is rarely over 15 mg. And the first pregnancy is usually an O mother with an A baby, or with a B baby. And then your RH is going to have more reticulocytes instead of spherocytes. Why is that? What's a reticulocyte? Y'all remember what produces reticulocytes or what they are? I know you got to send your brain back a little bit, huh?
Immature red blood cells.
Yes. So reticulocytes are immature red blood cells. So any kind of hemolysis is going to tell the body, hey, I need to push out more retics. And so what happens if you are the body can normally make red blood cells and push them out into circulation when they're ready, but if you're losing too much blood, then you're going to start pushing out reticulocytes before they're ready because you have nothing else. So if you can't remember which one, other than the R's go together, I mean, because that one's a pretty easy one too. But if you want to remember it on a foundational level, that your RH is more severe, so it'll cause more hemolysis, which will in turn create reticulocytes. Whereas ABO is going to have more spherocytes, it's less severe, and it's not full-blown hemolysis. You can take a chunk out and be okay. So then your RH will have a positive DAT, immediate jaundice, bilirubin often over 20 mgs, and usually not first pregnancy, and D negative mother with a D positive baby. So in which type of Hdfn would an exchange transfusion be more likely needed? It's going to be the RH because it's more severe to get pushed to the level of actually needing a transfusion. Was that what you were asking about earlier?
Yeah.
Okay.
Well, because it has a question. It just says, how do you interpret the appearance of spherocytes in a baby's blood smear after delivery?
Yep, probably ABO Hdfn.
Yeah.
So an exchange transfusion is a little different than an intrauterine transfusion. It's pretty much when there's too many antibodies in the baby's blood. Well, it's not really antibodies. It's mom's antibodies covering up too much of the baby's blood. So they're not broken down right away, but as soon as those cells reach the liver or the spleen, it's going to clean them out, which is going to cause, splenomegaly, hepatomegaly, problems in the baby. They'll lose red blood cells. They'll lose oxygen. So an exchange transfusion is the replacement of 1 to 2 whole blood volumes. It can correct anemia without expanding the blood volume. So it's not just saying, okay, here, I'm going to put all this blood into this baby that already has blood. It's going to take out the bad blood and put in the good blood. It decreases bilirubin levels. How does it decrease bilirubin? Any guesses? So what it does is it removes the antibody-coated cells that would be sequestered in the spleen, which in turn decreases the bilirubin levels. because you're not having the effects. Bilirubin's a byproduct of red blood cell breakdown. If you're stopping that breakdown, you're decreasing the levels. And it removes maternal antibodies. First, they determine the ABO or RH in the infant, and they use maternal or infant serum or plasma for the antibody screen. Why doesn't it matter whether you use maternal or infant serum or plasma?
What was the question again?
Why doesn't it matter if you use maternal or infant serum or plasma? They're all going to be maternal antibodies anyway. So whether they use the infants or whether they use the moms for the serum for the antibody screen, it's all going to be maternal antibodies because the baby hasn't had time to make them yet. So the units of blood are going to be, they have to be antigen negative for mom or baby. Again, generally it's mom, but they antigen negative for anything that they that could cause harm to the mom or the baby. And then you they're less than, I think the general rule is 7 days old, but less than 5 to 7 days old, and that's in reference to the blood, like when the blood was drawn out of a person. So if I went and donated blood tomorrow, 5 to 7 days from that day, that baby could have that blood. And then they generally use, I don't think it's a requirement, but it's recommended to use the CPDA1 anticoagulant. Do y'all remember how long that's good for? Your regular ones are 21 days. How long is your CPDA1 good for? 35 days. That's a really important one to know. So if you didn't know that already, I would definitely write it down. So CPDA1 is good for 35 days. And then the other requirements are the same as for intrauterine. You know, your hemoglobin S negative, CMV negative, B negative, all that good stuff. O negative, irradiated, any questions?